Welcome, everybody. Thank you for joining. My name is Adam Kalinowski. I'm the president of Dystonia Europe. One of the main core activities of our organization is connecting people with dystonia and physicians, and also providing the information for dystonia community. Every year we are hosting a big conference for people with dystonia from all over the Europe. Unfortunately, that year our conference called D-Days was cancelled for the reason we all know. And because of the canceling actually the biggest event in the year, we were searching for some opportunities to stay in touch with our member organizations, with patients, and also with providing the informations. So we decided to do more activities online. That's why we are here today. Yeah, now I will pass voice to Edwish, our Dystonia Europe Vice President. And Edwish, she will explain you more, she tell you more about our today's meeting and our guests. And I will see you at the end.
Yes, so hello everybody. So I'm happy to introduce this European webinar in English, sorry for my accent, as we have done it in French 2 weeks ago and it was a real success. So I'm proud to introduce our two worldwide known specialists today for this first pan-European webinar. They have met already 38 years ago, you told us, so they will form a great duo tonight. So Dr. Jean-Pierre Bleton, French physiotherapist, who is famous worldwide for his methods in focal dystonia rehabilitation and for his scientific studies. And Dr. Marie-Hélène Marion, neurologist consultant in London, one of the worldwide pioneers in dystonia field and botulinum toxin use. They are both also founders of the French Patients Organization for Dystonia. About the question, so please use the chat button that you can see at the bottom of your screen. So the chat one. So and please focus your question on cervical dystonia rehabilitation. Dr. Marion will take notes and ask them to Jean-Pierre Bleton at the end of his presentation. So don't hesitate, put your question here. So I'm sure you will learn a lot and enjoy this information. Dr. Marion?
Thank you for this very kind words. Yes, we met 38 years ago. We are not so old with Jean-Pierre. We met in Sainte-Anne, and yes, I'm delighted to be here. And of course, it's such an important topic, especially in terms of pandemic, when the resources of Botox is not available. I think we understand all that rehabilitation and self-management is a key of the well-being in dystonia, and in particular in cervical dystonia. So I mean, to have Jean-Pierre Bleton, who is one of the international specialists in this field, it's a real pleasure. And because we know each other well, it's like having a nice day together, a nice afternoon, talking about things that we really are passionate for.
Okay, Elvis. Thank you for, I'm very pleased to be among you. It's a pleasure to be with Marie-Hélène, Edwige, and Adam. I will start my talk. Okay. Everybody, thank you for joining us for this presentation on dystonia rehab in this time of lockdown. My speech will explain more specifically on tailored self-training. My presentation will be composing of three parts. Firstly, the basics of the motor control in cervical dystonia. Secondly, the management of self-training exercise. And thirdly, the modality, the expected result and the limits. As a preamble, this I have to say this presentation is not aimed at replacing your neurologist or physical therapist. It is intended to help you to cope with your condition by practicing tailored self-training and lead you to mobilize your personal resources in order for you to improve your posture and or movement. What should we know? In fact, the cervical dystonia definition teaches firstly that cervical dystonia is characterized by posture or movement disorder or both. Secondly, the head displacement is permanent or intermittent. That is, the abnormal muscular contraction is tonic or mobile. Thirdly, the head displacement is aggraved by the voluntary movement and holistic posture, which trigger an overflow of contraction of or abnormal muscular synergy. From this overflow, it's what I can say that it's the involvement of the dystonic muscle during an active contraction of the muscular of the head. And in conclusion, the cervical dystonia, its severity is depending on the state of the muscular tone, the movement you do, and the adopted posture. For better understanding, we must describe the different forces which act on the head and modify the posture and movement. This seems very complicated, but in fact, we have to resume the pathological disorganization of the movement in two main activities. If we observe this man, you can see an abnormal contraction of the right sternocleidomastoid, which produce a rotation to the left, and a lack of contraction of the left sternocleidomastoid, which normally reduce or modify the severity of the dystonia. In fact, there is an imbalance between agonist and antagonist muscle, and that the lack of equilibrium between these two kind of muscle explain the posture or the difficulty to turn the head. The main consequence of this imbalance between the different muscles. The inhibition of the corrective muscle leads to a muscular atrophy muscular atrophy of the inactive muscle. And there is a vicious circle between the lack of motion and the atrophy. The second point is the limitation of the range of motion, active range of motion. And you can see this lady, she can turn the head to the opposite side to the cervical dystonia, and she can't go until the head of the rotation. Not in this case. Sometimes the range of motion is good, but the majority of cases, there is an active limitation. Another point to observe is a difficulty in falling asleep. This is due to the most uncomfortable posture due to the permanent contraction of the dystonic muscle. But when you are sleeping, the cervical dystonia disappears almost completely. Another point is sensory trick or antagonic gesture. This sensory trick is a way to reduce the cervical dystonia. Nevertheless, it's not good to use it. It's better to avoid to use the gest antagonist and to try to modify the posture by the cervical muscle. Last point is the possibility to have some specific pain due to the tension of the dystonic muscle. The consequences is local discomfort and usually bearable. If you suffer from very severe pain, you should have a contact with your neurologist or a GP. I have to add another consequence of the cervical dystonia. The cervical dystonia is not only a muscular condition. It seems the dystonia affects also the sensory system, and when a patient is without the help of the sight of the vision, he can maintain a straighter head, and he replaces her head on the pathological attitude. And the perception of the posture of the head is one important point to develop during self-training. Nowadays, the first line treatment is a conjunction between botulinum toxin injection in the body of the dystonic muscle and an improvement, a specific exercise to train the corrective muscle. Unfortunately, the last week, many patients could not receive their botulinum toxin injection, and they had to treat their cervical dystonia only by exercise. And I will expect how to develop this party. Locally, active exercise are not a new concept. And all along the century, at the end of 19th century, until recently, many neurologists or psychologists or physiotherapists propose many options in order to reduce the cervical dystonia. In the 19th century, Brissot and Mage proposed a technique named psychomotor discipline. They proposed to their patient to stop the normal movement and to correct voluntarily the position of the head. Mage, more specially, proposed to place the head in the opposite side of the cervical dystonia, and he named this technique the mirror gymnastic. In the 70s, the behaviorist showed that it is possible to willfully influence the severity of the dystonic spasm. At this time, they used the EMG biofeedback, and they proved it's possible by his own willfully to influence the severity and to reduce the severity of the cervical dystonia. Recently, just before the introduction of the botulinum toxin injection, Rondeau, Gédinac, Ferret explained to the neurologists that physical therapy should always be recommended. He proposed to retraining the inactive or insufficiently functional rotational muscle in a context of relaxation. Their proposal stay almost useful. Nowadays, what we know about the treatment of physiotherapy for dystonia. Only 2 points are important to present. The first, the best result is the conjunction of botulinum toxin injection and physical therapy, but nowadays with the recent events, it's impossible to have the BONT, donc physical therapy alone is not enough, but it could be an option. And the second point is the EMG biofeedback. This proves the possibility to modify by his own willful the severity of the dystonia. We will focus on this aspect. Prerequisite for people carrying out a self-training program. The first point is to follow the exercise program established by your physical therapist. Don't use your own exercise, but follow the recommendation of your physical therapist or neurologist or GP. Second point is to define achievable goals. Don't be too ambitious and go step by step. Thirdly, carry out the exercise in a controlled manner. Very strictly, very analytically, you control very precisely the exercise. Few exercise, but well done. Other point is to keep a well-being when carrying out the exercise. You have to have a pleasure when moving the edge, like a dancer. You have to be very to feel a comfort when moving your head during the exercise. It's not a chore. It's a pleasure to move. And then, in order to see the result, you assess from time to time the efficiency of the execution of the everyday exercise in the everyday life, in the everyday activity. You can see if now you can walk with the head ahead, or if you can read without moving the head, you can see some specific activity modified by the exercise. You have to well know your dystonia in order to find exactly how to correct your head. Frequently, the head is disorganized in a three-dimensional manner. Example, if you observe this young lady, you can observe a left lateral collie, a right shift, on the left vertically. The head is turned, bend, go by on bend forward, bend lateralward, and have a shift on one side. This man have retrocollis, laterocollis, torticollis. This one has a retrocollis, torticollis, lateral, retro, and torticollis. You can see the disorganization of the head in the three the three plane of the space. It is very difficult to understand how is exactly your dystonia. For that, it's easy to observe in a mirror how is your head. For that, you have a mirror, you draw a vertical line for the midline, horizontal lines, one for the line of the eyes, another for the line of the shoulder. With the mirror, you can, in the mirror, you will observe your problem with your head. For example, in the case of a rotation, you can see this man, you observe the ears, you can see the left ear, but not the right ear. Is because the head is turning to the right. And it's a good manner to observe the rotation. And in order to correct, the patient has to replace the head and to see the two ears symmetrically. For the lateral bending, you observe you have the horizontal, you observe the line of your eyes, and the lateral bending is on the side of the slope. And you can see, in this case, a left lateral bending. This patient has a lateral bending on the left. The shift is more difficult to assess, but it is not so difficult. You have just to look two things. You observe the midline of the face. Oh, excuse me. You observe the midline of the face, the midline of the torso. For that, you observe the suprasternal knock. Just the sternum is here, just the superior part of the sternum. The vertical by this way, the vertical by the midline of the face, and you can see a difference, a gap between the two lines. Usually, the two lines are one the other. Another way to observe the shift is to observe the chin, the throat, Adam's apples, the sternum, and you have the vertical, and you can see the Adam's apple is there is a gap between the Adam's apple and the vertical. This is explained by the lateral shift to the right of the patient. Another point to observe is um, the shoulder girdle, and you observe if the shoulder girdle is horizontal or not. And in this case, you observe the line at the tip of the shoulder, the right shoulder, the line of the tip of the left shoulder, and you have a gap between us. This due to the position of the right shoulder. The reverse rotation is very frequent. When you have a torticollis in one side, the trunk turns to the other side, and you can see this man have a right torticollis and a rotation in the anti-clockwise of the shoulder girdle. And if you want to correct your head, you have to replace your torso in front of the mirror and correct the head if uncorrect your head. Another example of compensatory trunk posture, on the left figure, the lady compensates for the left torticollis by right rotation of the trunk. Or this man, on the right picture, the man compensates the right lateral bending by a curve to the opposite way in order to have the head the more vertical possible. Is inconscient and involuntary, but it's a compensation. And you have to replace the torsos, the trunk, before correcting the head. Sagittal shift is difficult to observe the shift on a mirror, and you need an external advice. Nevertheless, just for information, you could have an anterior shift. This lady is suffering from an anterior shift, or a posterior shift. And if you want to know the severity of the shift, you have the line, the horizontal line with the sternum on the tip of the chin, and you can see this distance which measure the severity or not of the anterior shift. Now, the rehabilitation exercise you have to practice by yourself. The first exercise, the well-known exercise, very frequently described, is the possibility to reduce the severity of the cervical dystonia by upper limb posture. If you have a upper limb elevation above the line of the shoulder, frequently you reduce the severity of the dystonia. I'll show you an example. This lady, you can see the difficulty to control the right sternocleidomastoid. There is an impersistence of the contraction. If she places her hand behind her occipital bone, you can see the quality of the contraction of the right sternocleidomastoid. This manner is a good way to reduce the severity and to help the rotation to the opposite side of the dystonic attitude. And an example of self-training. This patient is training by himself. He places correctly his torso, turn his head, a light touch just behind the occipital bone, and he controls the quality of the rotation of the head on a mirror placed on his left. Another way to turn the head to the opposite side is to turn very automatically without have a strong attention on your movement. I show you an example. This lady, she can turn the head to the left without difficulties, but as soon as she wants to turn to the right, she can't. It's very difficult. She can't. There is a co-contraction between the right and left sternocleidomastoid muscle, which block the movement. But if she say no with the head without attention, just say no with the head like that, she has no difficulty because it's an automatic movement, and she focuses her attention on her face and not on her neck. Another way to facilitate the rotation to the opposite muscle is to use the coordination between the eyes and the neck. There is a specific reflex, oculogyr reflex, and if you look at one side, you turn the head more easily to this side. Is a natural function, a natural coordination between eyes and neck. And if you are at your office, put your screen on the opposite side of your spasmodic torticollis, and you are a better control of the rotation. Another point is to train the deepest muscle of the neck, the muscle which maintains the head stabilized. For that, you have to reduce the lordosis, the neck lordosis, and you just do the double chin movement. You reduce the lordosis by a backward movement of your chin, and it's a way to train the deepest muscle of the neck. Concerning the exercise, the best way is to develop the ability to place the head to the other side of the spasmodic torticollis. For example, this man who suffer from a right torticollis, the movement recommended is to maintain the head and to turn the head to the left, and he control the posture of the head without going back to the dystonic posture in order to activate the corrective muscle or train them very regularly, without effort, low and slow, but regularly. This lady, which is suffering from a lateral shift, a right lateral shift, she places the head to the other side, and she places the head as she do Eva's dropping with the left hair. She places his hair against a door. It's a movement, a shift movement to the opposite side of the pathological shift. And when you train, you have to assess the quality, the successful execution of your muscle, of your exercise. This lady, for example, we suffer from a spasmodic torticollis. She's controlling the quality of the contraction of the two sternocleidomastoid, which works in unison. This lady, she's suffering from a right spasmodic torticollis. She controlled by a gentle touching the quality of the contraction of the corrective muscle. You have to be aware about the efficiency of your exercise. Excuse me. Another point is to feel the perception of the is according to the quantity of exercise. It's better to practice very short session, but very frequent session, and to try to control in the everyday life activity the placement of your head. For that, it's good to have a program, and the program have to be prepared by your physical therapist, and you have 1, 2, or 3 exercises with which exercise you have to do, on which side you have to carry over the exercise. Nowadays, it's good to use teleconsultation in order to have a face-to-face contact with your physical therapy, and it's possible to have a personal advice about your exercise in real time. The modality for the self-training in this period: a short but frequent session of exercise all over the day. I suggest from 2 to 5 minutes each 2 hours during the day. Many times, but short. Repetition, perseverance as the key, and you could act on the cerebral plasticity, and you could create a virtuous circle. And not feel guilty if you have some difficulty or sometimes you don't have a good performance. Don't have a performing anxiety. Be relaxed and not be afraid about the efficiency of the exercise. Train, and you will succeed. And do not afraid of turning the head to the pathological side, but try to have a well-conducted movement when the head turns to the side of the spasmodic torticollis. Try to be active, voluntary, and avoid involuntary movement. Perform the exercise calmly without any effort. Do you remember low and slow? Don't have any pain during or after the session of exercise. And in the day, take advantage of the good time and respect the fatigue. Enjoy practicing exercise. If it is a chore, usually you will stop it. You need to take a well-being when practicing exercise. And the most important is to follow the prescription and recommendation of your physiotherapist, neurologist, or GP. the result, the short-term result, I show you just is a pilot study in progress, but say data, unpublished data. But you see this man with left lateral collie, left torticollis, left lateral collie. And this is, it seems to be complex, but it's very simple. The blue line is movement of rotation of the head to the left, to the right, to the left, to the right. The midline is here. And when it turns to the left, he has no difficulty. When he turns to the right, he has many difficulty. He can almost go over the midline. When he trained during 20 minutes, the rotation exercise to the right, after 20 minutes of self-training, he can move more easily, to the left, okay, but to the right also, only he can correct to the left and to the right. Now the range of movement is not too bad. In a medium term, in an unpublished study, we run with motpradine on eye. We have observed that patients we follow a normal exercise, a usual exercise program with their physiotherapist versus self-training program have almost a similar result when we use a Twister score. The Twister score is a scale of severity of the dystonia. Nevertheless, the patient, we follow the self-training, a complaint about the difficulty to integrate the exercise into their working schedule. But in this time of lockdown, self-training could be a good option. At this time, it's difficult to see the neurologist and the physical therapist. Long-term result, the scientific literature does not mention any study on rehabilitation without the association of botulinum toxin injection. This is quite normal, insofar as there were no reason to do physiotherapy without toxin injection. But this situation is unprecedented, so we don't have any information about the long-term result of physical therapy without botulinum toxin injection. But nevertheless, we know that physiotherapy gives a good result in terms of quality of life, well-being, and pain reduction. And a study on other focal dystonia, such as musician or writer's cramp, shown a good result of the rehabilitation without botulinum toxin injection. So we can expect a good result with self-training during this period. In conclusion, the take-home message concerning the self-training rehabilitation, to pay calm attention on the movement disorder, to carry out short sessions of exercise, to experiment relaxation, all kind of relaxation, meditation, hypnosis, mindfulness, basis of stress reduction, all kind of relaxation. Don't practice carrying boring exercises and take advantage of the everyday activity in order to stimulate the head correction. Be active, avoid staying too static, keeping fit and practice sport is difficult presently, but artistic or leisure activity. and take have an interest, find other field of interest beside dystonia. Just, I would like to thank you for having attending that presentation. And now with Marie-Hélène, Marion, and I, we will be happy to answer to your question.
Thank you. Thank you very much, Jean-Pierre, for this presentation. I always enjoy and found the little new things that I learned. And especially the one of the image, because I think that when we all need image and to understand a movement, and I never be able to do myself a shift, okay, the horizontal shift like the ballet dancer. And when you say, and so I can't help my patient when they say you need to correct the shift. I say I can't do it myself, but and you say think about listening to a door, and that's right. And I did it, and I said, oh my God, the first time I do a shift now with my head. So you see, you have an image in your mind help you to do a movement. It's so important.
Yes, you have to have a reference.
Yeah.
In the everyday movement.
Yeah, it's very, so you have been I look at all the questions and the people from Europe everywhere, Belgium, Ireland, France, UK, listen to you, but also and Norway, but also people from Canada, Toronto, from US. So it's more than Europe. Yeah. So let's see the question. There is first of all, there is an Irish gentleman which called Steve who say hello. He met you 30 years ago, and obviously he had the DBS for his cervical dystonia, and he said my muscle have been wasted, has been atrophic since my cervical dystonia, even if the DBS work well to control the movement. And he said, do you think that I could rebuild the strength of this atrophic muscle if I do retraining?
My personal answer is not to train the strength, but to train the ability to contract. You have to maintain a low level of contraction, but it's better to have a good endurance than a strength. And if you repeat the movement, the atrophia, the quality of the muscular tissue will improve by the repetition. But it's
so not forcing, not with the strength. Yes.
Yeah, don't be too afraid about the body of the muscles, the atrophy of the body. If the movement is good, it's a good result.
Thank you. That's interesting. And the endurance is more important than the strength. Thank you. And one of these is he asked also about writer's cramp, because he also has writer's cramp. And he said, do you think that the physiotherapy and retraining can help writer's cramp? But I saw that you were quoting a paper that you published in Movement Disorder Clinical Practice.
Yeah, and there is a good and bad responder for rehabilitation for writer's cramp. Usually you have a good result for the bad posture of the wrist, and the bad posture of the forearm is is not so evident for the finger at the ulnar internal part. But we have shown with Marie Vidaillet and Sabine Monnier, Frédéric Bourdin, it's possible to modify the representation of the finger on the parietal cortex by the exercise. And in patients we recover only by exercise. There is a modification of the map of the finger, and probably it's possible to have a specific effect by rehabilitation, but in writer's cramp, we have not proved in spasmodic torticollis.
Okay, so carry on that about the plasticity and the patient with the task-specific dystonia like writer's cramp and musician cramp recovering representation in the head. There is two attendees who ask about Dr. Farias' method to retrain in dystonia, and what do you think about this method?
I don't know well this method. Have you some idea? You?
I have seen some patients who have been through Dr. Farias' workshop, and it's retraining, it's motor and sensory retraining, so it can only help the patient, of course. Yeah. So I'm not, I don't know the method exactly, but from what I get from the patient, it's a sensory motor retraining of the movement, so it certainly could help the patient.
Yeah, yeah.
Okay.
Probably the dystonia is capable to be modified by exercise. Yeah.
So a question of a lady from UK that I recognize her name. She says she's a lady with cervical dystonia, and she said, I found during this lockdown, I was playing a swing ball. Swing ball is, can I say a word in French? C'est le jokari. So, you know, it's this ball which is attached to a box and you tap into it and it's bounced back. And she found it very helpful. And I think that when you finish your slide saying you need to have pleasure to do exercise, and it's true that this ball game, turning, following with your eyes as you explained.
Yeah, probably the bite points is to focus the attention of the neck. And if you turn your head on, you focus your attention on your face or your head and forget your neck, you improve and the movement is more spontaneous.
Exactly. I have patients who play table tennis and they love it because they look at the ball, so they don't think about their neck, as you say. So it makes them more mobile.
The oculocephalogeal reflex.
Yes, exactly, what you explained very well. Thank you. So there's a patient who say, a lady from Toronto, and she said, I got secondary hemidystonia, and she's struggling to find a position to sleep. And she also feels dizzy when standing. So I can answer for the dizzy when standing because she said, what can I do for my dizziness when standing? And I think that's more related to the brain hemorrhage. And I can say to this lady that certainly vestibular physio retraining is very powerful, and it's very different from retraining of dystonia. But for dizziness triggered by movement and by posture, she will certainly benefit from having vestibular retraining. I'll let you respond for the position in sleep.
In sleep, when sleeping, no problem, because the cervical dystonia disappears almost completely. But the difficulty is to feel asleep, and to feel asleep is the best position is the more comfortable position for each of you. If you are well in one position, you feel asleep, and during the sleep, the head will be free.
I agree with you.
Avoid to correct your head because you have a fight between your posture and your dystonia, and you increases the abnormal posture.
Yeah, I think this type of patient could benefit from listening to, you know, there is a lot of app on mobile phone to fall asleep with meditation, hypnosis, and that's really can work very well. You put a 10-minute session for falling asleep, and as soon your mind relax, your muscle will relax, and you will fall asleep. So I ask also, there is a question about do you think that the temperature, so the weather, has an influence on the cervical dystonia? I don't think so myself, but I can't comment. I know that, for instance, Parkinson's patients don't, when it's hot, it's not ideal, but
probably warm temperature is better for the muscle because it's more relaxing.
Yeah.
It's the only thing I can say.
Yes, exactly. I agree with you. Yes. There is one who asked, do you think that to retrain, I need any physiotherapist or a specialized physiotherapist in dystonia? My answer will be between a physiotherapist and somebody who do specialize in dystonia, it would be nice to find a neurophysiotherapist, because usually the physiotherapists who are used to neurological patients are better to help this type of problem.
Or what I can say, it's the physiotherapist has to observe the patient as suffering from a neurological condition, not an orthopedic condition.
Voilà.
It's he use motor learning, not biomechanic of the spine.
Exactly. So I think it's a neurophysio. After that, if they are specialized in dystonia or not, they can read, they can learn, they can.
Yeah.
There's a lot of things out there. Could you tell us also? There's some question for me, so I will keep them for the end. But it was a good question about if you have a retrocolis and you don't have access to the botulinum toxin at the moment, what do you will advise this patient? We know retrocolis is one of the most severe ones.
Yeah.
What you will advise?
In order to reduce retrocolis, you have two options. The first is to maintain the head forward and relax in order to use the gravity force to reduce the retrocolis. And you stay like that in relaxation, and you have you stop the bad contraction of the extensor. The other point is to reactivate the longus colli muscle. This muscle reduces the lordosis, and you place your head in double chin in order to control the bad lordosis, the overlordosis by the contraction of this muscle. These are my two pieces of advice.
I agree. You show it lovely on one of the slide, how to correct this patient lying down to correct the normal curve of the neck, and just doing a double chin will straighten the neck. I agree with you. It's an antagonist posture for the retrocolis. The double chin will be very good.
Just a point is to maintain the posture and not do too dynamic exercise, because you stimulate the contraction of the muscles. You place and maintain and relax.
It's what you meant before with endurance, and it's very, very interesting. I still learn. Thank you. There's a lady from Romania, you see, from Romania, everywhere from the world, and she's asking, do you think that the exercise which are the re-strengthening exercise and the exercise which are more she said reposting, so more relaxing exercise can be done the same day, or do they have to be done in different day or in the same session?
I prefer you focus a session on one or two exercises, and you have time for relaxation. It's a permanent concept. You have to try to be relaxed, not relax just at some certain time. You relax always, always low and slow. On the basic contraction, basic tone, you move and you relax and move.
Yes, and I think that Mej, Mej, in 1929 in his review, he said it's very, very important to relax all this muscle and to to get that. And if one day you don't feel that you can do it, just drop it. Don't push, don't force. You are saying the same thing. It's very interesting. So it must be true if a century later we say the same thing. I wanted to, now it's maybe a little bit, maybe it's for you still, it's about the pain. A lady says, a nerve pain, what can I do? I've tried the Botox, I've tried physiotherapy, and nothing works. So I'm happy to answer to that. If...
The pain is probably a more neurological problem is for the neurologist, but usually it's the pain is due to the muscular tension. The movement, very gentle movement of the head and neck relaxes the muscle. If you move, it's like internal massage, and you relax your muscle. But if the pain is due to an orthopedic problem under the dystonia, you need to be referred to your neurologist.
And just to bounce back on your answer, a lady asked you, if does the constant movement of the neck in cervical dystonia can cause arthritis, and what is the best treatment?
The mobile form of dystonia is very difficult. Is the worst for the rehabilitation.
The tremulous one, yes.
Yeah, and usually the objective is to stop the abnormal movement and just maintain the best relaxation. And if the movement is not too strong, there is no defect about the orthopedic about on the rashes and the spine. But if the movement is very severe, you could have some injury, look for mild, but injury by the repetition of the movement. And
but it's when it's very severe. I agree with you.
This is too severe. I refer to the neurologist here. Probably we have to discuss about DBS.
And tablets and different things. Yeah, and for the pain, I will add that there's a lot of different pain. There's a pain due to the muscle contraction, and you describe how well we can relax them and get them better with movement. There's also some more chronic pain, not acute pain, but chronic pain. And these chronic pain are not due to a direct lesion, and they need to be dealt with some sensory retraining, and it's more difficult to. But of course, that will most often the Botox will not work on this chronic pain, and patient has to check also the level of anxiety, the level of depression, how they feel in their body. And I will answer to the question about anxiety. There was 2 questions for me about mental health, and we discussed it in previous webinar that patient with dystonia has been shown scientifically that they have 4 times more risk of more high level of anxiety and of panic attack. And so certainly, yes, we know that anxiety can be very quickly triggered in dystonic patients, and dystonic patients are vulnerable for anxiety and depression. And certainly the question said, do we need a mental health team? I think you need to talk to your neurologist or your physio, what is most easiest to do, but certainly it needs to be taken into account in the treatment as a holistic approach. I agree with the patient that it needs to be, doctors need to be aware of that. And there was another question. No, I think we have done, and there was another question about spreading. And there was a patient, the first question was about, had I lead the dystonia, then jaw, then neck dystonia, and it's spreading over the years, and what's happening? And I would say it's a mesh syndrome, talking about mesh. Cranio, cervical, cranio means the face, craniocervical dystonia. And we know that some dystonia can start with the eyes, spread to the lower part of the mouth, spread to the hair, and spread to the neck, and give some swallowing difficulty or speaking difficulty. And yes, it's difficult to treat. And we know also that some patients with cervical dystonia can spread to the mouth, or but it's very rare, it's about 10%. So the common spread is more up-down than down-up. And that's it. I think maybe there was a new question when I was talking, how many self-training sessions a day, but I think you have answered to that. Even if the results is more pain, should we carry on? I mean, you answer to that. Don't do movement if it's painful. And you say that 2 to 5 minutes.
Search session, few minutes frequently.
Voilà. So that's
in order to have the habit to replace your head on the good side.
Any advice for those of us who have not got the option for a consultation with a physiotherapist? I think you should have an option, not a specialized physiotherapist, but any physiotherapist.
Yeah,
I think that in every country there is a physiotherapist,
yeah.
And now with the time of the webinar, I mean, everything is so much available. And one of the patients said, "Oh, I wish my physiotherapist is going to see this presentation." I think it's a very good idea. But even if we can't give away our presentation and our slide, they will be on Dystonia Europe YouTube channel, and physiotherapists can access them. And I think that a lot of the panelists, the patients who are listening to us today, I think it's a fantastic advice. If you have a physio, you are in the middle of nowhere, he has never seen a dystonic patient, please send him to the webinar of Jean-Pierre, and he will learn very quickly, because everything it was so well detailed, and your slides are so explanatory that that's perfect. That's how you train a physio, and they understand well very quickly. So do you want to add something, Jean-Pierre?
No.
Finish? To end of the session?
I have actually a few things to add. I will try to be very brief. Because first of all, I think we have got a big piece of advice and information from you. And since I've seen nobody from the attendees left the webinar during the webinar, so that's also a good sign. That was very interesting and helpful. And yeah, of course, I understand, and I have seen many questions about if we will share the recording afterwards. So I know there were plenty of information on that webinar, and it's really hard to remember that. So we will share that webinar recording on our social media. So if you let me quick share the screen. So here is our website, dystonia/europe.org. So if any of you will go to that website, on the top you can see all our social media channels. So just follow it, and you can expect the recording there from that presentation.
Adam?
Yeah.
Adam, can you show to attendees how to find their national patients organization, please, in the members menu?
Okay, that could be very useful.
Because I have seen a lot of questions. How can I find a physiotherapist? Please do not hesitate to contact your national patients organization. They have all information, and I'm sure they know how to contact a specialist.
Okay, so first I come back to the homepage, and then on the homepage about us page, you have sub-page called members.
Yes.
And then Dystonia Europe has 22 national member organizations from 18 countries so far. So it's a lot. And here we have full list of 21 or 22 organizations. If you try any of them, let's say France, yeah,
Why not?
Because we have a lovely photo here. You have contact details and the website, the social media. So yeah, you can also try to find the contact on your local level through our Dystonia Europe website.
Thanks.
And
Can
also,
can I say something?
yep.
Sorry, I forgot. There was a lot of other questions that I missed, so I must apologize to people who asked questions. And there was two questions that I think it's important to answer. There was what about chiropractic and cervic and dystonia. I mean, my opinion is that it's not appropriate to do chiropractic in dystonia. What do you think, Jean-Pierre?
I agree. It's not orthopedic problem. It's not a vertebrae problem. It's a very motor control problem.
So you agree? We agree. And there was another question. Was interesting. It's a patient who say, my head is my neck pull my head like a turtle, trying to pull its neck into a shell. My neck contracting my shoulders. I think she meant this double chin posture, like a turtle. And my advice will be to do the antagonist gest and to do the goose neck.
Yes, for the goose neck, you have to activate the deepest muscle of the neck in order to create a lordosis, but it's very difficult, and it's your specialty to have a gesture.
No, but yeah, but for this patient who have this really, if she meant to be, it's a good image, the turtle, because I like image, and this double chin posture like that, certainly to do the antagonist posture, which is to pull like a goose very, very forward, will really relax and stretch a muscle.
There is
sorry, so...
Oh, just a point. There is, for the posture of the neck, you have an equilibrium between the longus colli muscle in front of the spine and behind the multifidus. And you have a lack of equilibrium between these two group of muscles.
Yeah, we could talk about that later. Okay, so thank you, Edwige. You can go back, and Adam, sorry, we apologize.
Okay, also I want to add from the patient point of view, I have cervical dystonia for many years, and what's like take my attention from your presentation, that being static, it's not good for us. Actually, being static with dystonia, it's very difficult, but I know what you mean. I know from my own experience, if I'm, especially now during the lockdown, if I spend too much time indoor or front of the TV or computer, my symptoms are getting worse and worse. And what was surprising for me, and you mentioned that also in your presentation, that if we focus from, in my case, from my neck to other parts of the body, other movements, I can agree with that, because 2 years ago I started surfing, and I always dream about it, and I never thought I will be able to do that. And if I'm actually when I'm in the water, and there is so many things that you need to focus on: waves, your body position, your board, other surfers. And then I found that sometimes I just forget about my neck, and it's much easier for me to do this kind of exercise. So I totally agree with that point. So yeah, we have still questions coming, but yeah, so maybe if we will share our that video on our social media, there people can ask more questions on the comments, yeah. And also, we as a Dystonia Europe, we want to keep going with a series of webinars on the different topics, because that was more focused on cervical dystonia, and I believe there is a maybe more than 30 types of dystonia, and even every type can have a different case. So we want to focus also on the well-being, because I think in today's days that's very important. And so, yeah, keep follow our social media, and we will, I believe we will manage to find another such a great specialist that will be very helpful with doing that. So thank you very much for all our panelists, and thank you for all attendees for your activity, for your questions, and for being here.
Thanks a lot, Jean-Pierre. Thanks a lot, Dr. Marion. See you later.
Okay, see you
Bye-bye,
later.
everybody.
Bye.
Bye.